In this presentation, I'm going to present the findings from a qualitative study of abdominal aortic aneurysm screening program staff's views relating to the introduction of multi-component cardiovascular health screening into the existing NHS abdominal aortic aneurysm screening programs in the UK. This qualitative study forms the early part of a larger program of work that has been funded by the NIHR. The larger program of work that this qualitative study is based on is called FAST, and it looks at the effectiveness, cost-effectiveness, feasibility, and acceptability of adding screening for peripheral arterial disease and high blood pressure to the NHS abdominal aortic aneurysm screening programs. Screening for cardiovascular disease risks is important because of the burden of cardiovascular disease in the UK. The NHS long-term plan has also identified early detection and treatment of cardiovascular disease as a priority for the NHS. The main NHS preventative strategy for the management of cardiovascular risk is the NHS health check system. However, attendance for these health checks is regarded as suboptimal. Detection of peripheral arterial disease and high blood pressure offers an important means of identifying individuals at high cardiovascular disease risk. However, both these conditions remain underdiagnosed and untreated. Within this context, the NHS abdominal aortic aneurysm screening programs, with their high uptake, represent an opportunity to screen for possible cardiovascular disease through the addition of peripheral arterial disease and high BP screening to the program. And as part of a wider program of work, we explored NHS abdominal aortic aneurysm screening program staff's views regarding these proposed screening additions to existing abdominal aortic aneurysm screening programs. This study involved 9 focus groups and 7 follow-on semi-structured interviews. The focus groups were undertaken at FAST device selection meetings, where as part of the FAST program, NHS professionals across England with experience of working in abdominal aortic aneurysm screening were invited to attend one-day workshops to try out different peripheral arterial disease and BP screening devices. After an introduction to the FAST program and hands-on testing of the screening devices, focus groups were undertaken with the attendees. This was followed by follow-on telephone interviews with a few of the participants. In total, 38 program staff took part in the study, representing 12 different NHS abdominal aortic aneurysm screening services across England. The participants represented a variety of roles, including screening technicians, program managers, clinical scientists or clinical skills trainers, and abdominal aortic aneurysm specialist nurses. All focus groups and interviews were audio recorded for transcription, and data collection continued until reaching thematic saturation. The data were analyzed using thematic analysis and an inductive approach to coding. 3 main themes emerged from the data. These are perceptions of patient experience and health-related outcomes, opportunities and challenges for program staff, and maintaining and improving program standards. I will now discuss these themes in more detail. Participants' views regarding the proposed introduction of peripheral arterial disease and high BP screening into the abdominal aortic aneurysm program were overwhelmingly positive with respect to it being an opportunity to improve health-related outcomes for attendees. Screening staff unanimously saw peripheral arterial disease and high BP screening as something beneficial that would enable picking up on conditions that wouldn't be picked up on otherwise. And the abdominal aortic aneurysm screening program was viewed as a particularly effective means of ensuring good coverage because you've got this whole 65-year-old group of men coming to you, so the opportunity to make sure you don't miss anybody. Alongside an emphasis on how abdominal aortic aneurysm screening's high coverage was helpful, participants suggested the multi-component aspect of the proposed screening is likely to also receive a positive response by attendees who will appreciate it because they'll see more of a health checkup and they'll be quite keen to come. Participants highlighted that the positive health outcomes from the proposed screenings were, however, largely contingent upon adequate follow-up in terms of provision of cardiovascular risk management support, suggesting that an important question to address was, in case if the GP doesn't action it, what backup plans do we have? The participants thus raised the potential for inaction on the part of GPs and noted that the additional screenings could introduce a lot of additional work, only to find that nothing happens in terms of patient follow-up. Participants suggested things they would like to see put in place, such as clear actionable guidelines and protocols for GPs to follow, and initial input from abdominal aortic aneurysm screening vascular nurses. Participants also envisaged that the proposed multi-component screening would have the potential to be experienced favorably by screening attendees insofar as it allows getting more tests to be done within one appointment. Effective management of time to make the appointment as efficient as possible for the patient was hence identified as critical to ensuring that the screening additions did not impact negatively on patient experience. Emphasizing particularly that abdominal aortic aneurysm screening requires a simple ultrasound scan, some participants characterized the proposed screening processes as potentially more complicated and suggested the need to find tests that are easy to administer. Furthermore, participants highlighted their own interactions with screening attendees as contributing to positive patient experience and suggested this aspect needed to be retained within any reworking of future screening schedules. Participants viewed the proposed screening additions as a good opportunity for developing and diversifying the screening technician role. It was observed that abdominal aortic aneurysm screening technicians have a fairly limited role, which can get a bit monotonous and hasn't really got a career path to go on from that. Abdominal aortic aneurysm screening program managers further highlighted that this has also meant that it's quite a hard role to recruit to. Within this context, the introduction of peripheral arterial disease and high BP screening was regarded as a hugely positive step to take. The benefits for screening technicians were identified as not merely including a diversification and greater transferability in their skills, but also the development of a more fulfilling work role, one which provides extra development and something to challenge the brain, along with providing the enthusiasm to want to come into work, to be enthused to impact patients and to benefit patients. Peripheral arterial disease and high blood pressure screening were characterized by many participants as involving additional longer processes and being a whole different game to abdominal aortic aneurysm screening. Participants emphasized that while the premise of such multi-component screening is good, there would need to be a lot of thought into the actual day-to-day operation of it. Describing the time and resource constraints experienced within their existing screening context, participants identified the proposed additions as a potential challenge, whereby they may be required to manage the number of patients they need to see every year against the time it will now take at adding on the additional tests. Participants noted, however, that these challenges may be addressed through provision of sufficient resources, suggesting if that's costed and staffed, that is not insurmountable. Participants also envisaged that the additional screening would inevitably reconfigure their roles and responsibilities together with work relationships across organizational boundaries. Screening technicians in particular talked about GPs being dismissive of them and suggested that undertaking the additional screening may garner more respect for the screener's role. While expressing enthusiasm for a diversification in their role, participants emphasized requiring a bit more of clarity regarding the expected responsibilities of the role. The screening additions were hence not perceived as necessarily unambiguous extensions to their screening roles, but ones which potentially redefined and could complicate the boundaries and remit of their existing role and its responsibilities. As one participant explained, as standard practice for a screening technician, you're not there to diagnose, you're not diagnosing for aneurysm screening, but you're almost being asked to diagnose for peripheral arterial disease. You'd gotta be careful not to step on the toes of the GP. An important concern of the screening program staff with regards to the introduction of the additional screening also related to the maintenance of and improvement in screening program standards. Participants noted the declining abdominal aortic aneurysm detection rates, observing that at some point in the future there's likely to be some diversification within abdominal aortic aneurysm screening. And in this respect, the incorporation of additional screening future-proofs AAA screening and ensures the continued viability of the screening program. By looking upon this prospect favorably, participants nonetheless highlighted the high standards of quality maintenance and service delivery within the Abdominal Aortic Aneurysm program, stating that they would hate for that to be put in any sort of a detriment as a result of the proposed additions. Maintaining the existing program standards was hence identified as an important consideration. These standards were invariably described as relating to the level of care provided to patients, safety, hygiene and infection control, appointment timings, accuracy of test results, adequate follow-up, etc., and included formalized processes and assessments. Participants stated that they were assessed regularly to make sure they're maintaining the standards, and they needed the equivalent for peripheral arterial disease and high blood pressure screening. In addition to emphasizing the high standards of service delivery within the existing screening program, participants also saw some potential for improvement through the addition of the proposed screening. Two areas that participants identified where they saw an opportunity arising for improvement related to the provision of written results to screening attendees who do not screen positive for an aneurysm, but are then ringing up again wanting to book, and they've already had it, but they've got no memory of it. And secondly, opening up screening locations, getting a wider group of surgeries on board, and spreading the message a bit more. In both these cases, participants suggested that the new processes, resources, and roles and relationships developing as part of the additional screening could help improve abdominal aortic aneurysm screening program as well. Our study findings suggest that abdominal aortic aneurysm screening program staff viewed the addition of peripheral arterial disease and high blood pressure screening to the NHS abdominal aortic aneurysm screening programs as a positive development. Participants, however, identified that the benefits of incorporating the additional screening would be largely contingent upon a number of appropriate systems, structures, and resources being put in place. These related in particular to the potential challenges anticipated around three key areas that needed to be addressed, and included ensuring adequate follow-up support for cardiovascular risk management, maintaining clarity around roles and responsibilities, and availability of sufficient resources for the program. Overall, our findings reveal multiple challenges along with possible opportunities as identified by the screening program staff, linked with the proposed multi-component cardiovascular health screening program. A key issue that follows is regarding the complexities surrounding who may be best placed to implement such a program, and whether the drive for such a program needs to come from within or outside of general practice, considering that cardiovascular risk management typically falls within the remit of general practice. The appetite among screening program staff with respect to the development of their roles is clear from the data, along with an expectation that the proposed program could potentially offer important benefits for the abdominal aortic aneurysm screening programs. At the same time, however, the data also reveals some ambivalence among program staff with respect to the boundaries of their respective roles vis-a-vis GPs, as well as their own access to adequate resources and systems for the effective performance of their proposed role. In an existing context of low uptake of the NHS health check, the NHS abdominal aortic aneurysm screening programs could potentially offer a more pragmatic pathway for peripheral arterial disease and high blood pressure screening. The feasibility, acceptability, effectiveness, and cost effectiveness of this proposed pathway will be tested within the next stages of the FAST program. To sum up the main key points from this study's findings, the program staff simultaneously identified both opportunities and potential challenges linked to the proposed screening additions to existing abdominal aortic aneurysm screening programs. These views provide useful insights regarding staff concerns and priorities relating to the proposed screening additions. While the additional screening offers potential benefits, the specifics around how this is introduced in practice requires taking into consideration the challenges highlighted by program staff. The full version of this paper is now published and available at BMC Health Services Research. This project is funded by the NIHR, but the views expressed are those of the authors and not necessarily those of the NIHR or the Department of Health and Social Care. We would like to thank Dr. Emma Chung and Dr. Emma Watson for their assistance with the study. We would also like to thank all our study participants for their time and valuable contribution. Thank you for listening.